Thank you for the opportunity to tell you more about the Remind project. Remind is based in Baltimore, Maryland, and is a workshop-based curriculum to equip public defenders to most effectively represent clients experiencing mental health and substance use challenges.
With client-centeredness, we cherish the dignity and humanity of individuals whose autonomy is in jeopardy. In believing healthcare is a human right, we say that it is unacceptable that any person in need of medical care would be denied that support because they lack resources. The criminal justice system is not a solution to any public health crisis. We can't incarcerate or criminally sanction our way to healthy, safe communities and individuals. Experience matters. People experiencing arrest or incarceration deserve respect. They deserve strong relationships with their advocates. We start where the need is greatest. Poverty and mental health challenges create enormous disadvantages to people involved with the criminal justice system at any stage. And communities can do better. Along with clients themselves and their defense attorneys, clinicians, social service providers, and other allies can bear witness to join efforts to protect the health and safety of anyone facing criminal sanctions. In strengthening client-attorney communication and trust, we focus on criminal defense attorneys as the only dedicated advocates for clients' stated interests after an arrest. Effective relationships close the gap between stated interests and best interests by informing clients of their rights and options and attorneys of their clients' experiences and goals. We use client-centered communication techniques to overcome the barriers of the trauma and complexity of involvement in the criminal justice system. In informing attorney advocacy strategies, we educate attorneys about unique strategic and advocacy concerns that apply when a client faces mental health or substance use challenges. In cultivating a network of resources to support attorneys and clients to achieve better outcomes, we bring the expertise of former clients, clinicians, service providers, and other allies to the table to address the vulnerabilities individuals face at the intersection of mental health challenges and the criminal justice system. Remind is not a diagnostic process, and it does not rely on the assumption or profiling of mental disorders. For one, attorneys are not appropriate arbiters of medical diagnoses. Further, most of the principles of relationship building and strong communication are not specific to any particular mental health issues. Finally, mental health experiences can be fluid and are sensitive to stress and trauma. We hope to prevent the worsening of emotional, psychological, and psychiatric challenges, including those that may not be pathological. Remind will extend to all public defenders who serve clients in Baltimore City. The training will function more as a workshop than as an instructive forum. From my piloting and research, it's clear to me that while public defenders are capable and experienced with the situations Remind seeks to address, they at times lack perspective and confidence that they did right by their clients. What I'll offer by way of instruction is largely framing and structuring ongoing information sharing and developmental relationships across the agency. We'll offer 3 modules: developing client relationships, doctrine and strategy, and advocating for and with ourselves.
Basically a model of communicating that helps us build better relationships with all of our clients. I found it to be effective when we're talking to folks who, and again, these issues in terms of addiction and mental health problems exist on a broad continuum, but whether folks are severely impacted by that stuff or not at all. And I found it to be a great way to just build trust and build good relationships, which sometimes is all we can really offer our clients, because again, it is very difficult to win cases. But I like to think that has some meaning. At the very least, it's the best thing we can do for folks sometimes. And sometimes it's also a necessary component of winning their cases and getting good outcomes, particularly at the trial level. It can actually help facilitate keeping people out of jail and prison.
Hello, I'm here to tell you about our project on addressing substance use stigma among health profession trainees using a massive open online course. It's funded in part by a SAMHSA expansion of interprofessional healthcare practitioner SUD education grant. The course is 100% online on the Coursera platform with the title Addiction Treatment, Clinical Skills for Healthcare Providers. The course is self-paced with 24-hour and lifetime accessibility for all materials. The course was developed by an interprofessional team of Yale faculty from public health, nursing, medicine, PA program, and the Yale Poorvu Center of Teaching and Learning, as well as the American Academy of Addiction Psychiatry. The course content was built upon an existing foundation course and expanded upon by the development team that met, reviewed, and updated content over 2 years. The platform allows for continual updating and improvement. The course is composed of 6 separate modules containing 3 to 5 interactive video lessons. Each module can be completed in 45 minutes to an hour. Course components are video didactics and animated concepts, interactive case vignettes, and interprofessional panel discussions. Additional components include quizzes at the end of each module with automated grading, an interactive map activity to identify local treatment options in the learner's geographic area, interactive discussion forums for questions and comments, and additional downloadable clinically focused documents and materials. Importantly for this presentation, 2 modules directly focus on explaining and addressing stigma, and were designed to address clinically specific goals, the first being, how can I show compassion towards patients with SUDs? This module focuses on models of addiction, stigmatizing language, and motivational interviewing. The second addressed what societal factors impact successful recovery and focuses on stigma, structural determinants of health, U.S. history related to SUDs and social disparities, positive policy changes, and finding quality treatment. For our pilot project, we recruited more than 34 nursing, pharmacy, social work, medicine, and physician assistant programs. Recruitment has involved multiple phases as well as an open access course. 746 students and trainees started the course in Phase 1, 485 in Phase 2, and 407 in Phase 3. More than 25,000 have started the open access course. The results presented are from Phase 2 since few participants from Phase 1 completed the follow-up assessment. Of those students and trainees who started the course, 65% completed it, and 56% of those completed our post-course assessment. The results presented here are based on a 10-item assessment of clinical self-efficacy, or confidence, in providing care to patients who use substances, including screening, diagnosing, discussing treatment options, and providing supportive care. As can be seen in the figure, student self-efficacy increased substantially from pre-course to post-course. Our project indicates that despite widespread stigma, health professional educators are eager to utilize online introductory SUD education, and healthcare professional students can be engaged and enthusiastic with addiction content through an interactive online course. Despite limitations in the study design and lower than expected response rate, findings suggest that an interactive, online, and foundational substance use course, including significant stigma-focused content, can substantially improve self-efficacy in addressing substance use among healthcare students and trainees. Our project is the culmination of a truly multidisciplinary team of co-authors, collaborators, and advisors listed here, as well as the American Academy of Addiction Psychiatry, the American College of Academic Addiction Medicine, the Yale Center for Teaching and Learning, and the faculty champions at participating schools and the Project Advisory Board. Thank you very much for your time.
Hi, and welcome to our presentation, Collaborating with Community Partners to Develop a Harm Reduction and Stigma Curriculum. My name is Sandra, a primary care provider in the San Francisco Health Network and curricular lead for this project.
I'm Jari, and I'm a first-year medical student at UCSF.
Hi, I'm John.
And I'm Sad.
And we're health educators with the Syringe Access Services Department here at the San Francisco AIDS Foundation.
We'll be your presenters today, and also wanted to highlight some other key members of our team, shown here. By now, many people are familiar with the opioid epidemic. Over the last few years, there have been sharp increases in mortality from drug overdoses across the nation, driven by the introduction of fentanyl into the drug supply and made worse by the COVID-19 pandemic. In 2019, 441 people died of drug overdose in San Francisco. This number rose to 700 deaths in 2020 and continues to rise rapidly. In response, a pilot was launched where community primary care clinics were identified as sites to distribute intranasal naloxone and safer consumption supplies to at-risk patients, with the goal of preventing overdose deaths, increasing safety around substance use, and access to harm reduction services. Our project aimed to develop a training curriculum that would educate providers and serve as a foundation for these pivotal patient interactions. When we were initially developing the training, we were focused on thinking about how frontline staff could be trained on how to use intranasal Narcan and the safer consumption kits. However, our community partners at the SF/AIDS Foundation, with their experience in serving the community and their own lived experiences, said, that's the easy part, to teach that stuff. What's hard is addressing the main barrier for people who use substances, and that's stigma. And stigma starts way before the clinic encounter. It starts in the waiting room, at the front desk, with the environment. Then there's stigma from others, clinic staff, providers, and then there's self-stigma or internalized stigma. And all of this serves to keep people away. And there's no point in having all these supplies and services if your patients can't access them. We need to address stigma. So we developed a training with 3 components, with the harm reduction and addressing stigma session as the foundation, followed by an overdose prevention and intranasal naloxone module, and videos created by the SF/AIDS Foundation reviewing the safer consumption kits. One thing that was important to us was including the voices of people with lived experiences as experts in their own care, both in the development of the curriculum and through the power of sharing their stories. The Harm Reduction and Addressing Stigma session is a guided discussion-based session that is conducted at each pilot clinic site. We talk about basic harm reduction principles, the effects of stigma, and how we can address it. We also learn and hear from our community members who share their experiences with stigma and harm reduction. The training provides a safe and protected space to start a conversation that we hope will continue long after the training. Before the training, we meet with each clinic site champion beforehand to discuss the specific educational needs for their clinic, and then tailor the training accordingly.
About our overdose prevention or Narcan module, it was built using Google Forms with material provided by our collaborators at the Joe Project, supplemented by video narratives and interviews shared by our community partners at the SF/AIDS Foundation with lived experiences of responding to an overdose. The module is super interactive with questions scattered throughout it, and it's pretty simple in terms of its learning objectives. It goes over how naloxone works, when to use it, or in other words, how to identify an opioid overdose and how that's different from being high, and how to respond to that overdose in a way that's really trauma-informed. So using the Narcan, calling the emergency services, etc.
We recorded these videos on safe consumption kits and fentanyl test strips to explain supplies and how to use them.
We asked other health educators with the Syringe Access Services Department here at the San Francisco AIDS Foundation to record these videos. These videos are designed to educate providers and other clinical staff on substance use and harm reduction to break the barriers to stigma so that substance use can be talked about openly and honestly between patients and clinicians in clinical settings and improve health outcomes for all involved.
In terms of evaluating the effectiveness of our harm reduction and stigma training, before the training, we have participants complete a survey that tells us to what extent they interact with people who use drugs, as well as their levels of drug-related stigma. Post-training, we assess changes in that drug-related stigma, as well as changes in people's perceptions and practices around harm reduction. That's all we got for now. Thanks so much.
Hi, my name is Stephanie Hooker, and today I'm going to talk to you about our intervention to reduce stigma among primary care clinicians towards people with opioid use disorder. I'm at the Health Partners Institute in Minneapolis, Minnesota, and my co-authors are Lauren Crane, Amy LaFrance, Gavin Bart, and Rebecca Rossum. So our team has developed an opioid use disorder clinical decision support tool, or CDS, that helps clinicians screen, diagnose, and treat patients with OUD. This is just a screenshot of our CDS as embedded within our electronic health record. And the CDS is designed to reduce many of the barriers to care for patients with opioid use disorder, including helping clinicians feel more confident in their ability to treat opioid use disorder. However, we know stigma is another barrier to care, and in our literature review, we found that many clinicians carry many of the same stigmatizing beliefs as the general public, including believing that patients with opioid use disorder are responsible for their illness, that they're undesirable, angry, or dangerous, and few interventions have been directly tried to reduce clinician stigma. Some of the best approaches there are direct contact with patients with opioid use disorder or hearing positive narratives about patients with the use disorder. So the goal of our project was to determine whether we could actually reduce clinician stigma by infusing the stigma reduction content into our training for our CDS. And the overall aim of the project was to reduce clinician stigma. We also wanted to increase intention to get waiver to prescribe buprenorphine or intentions to prescribe buprenorphine if the waiver weren't required, and also trying to increase the likelihood that the clinicians would use our CDS tool in practice. So here's the design of our study. We have 15 clinical clinics that are primary care clinics that have been randomized to receive our CDS tool in the larger trial. In those intervention clinics, we've randomized clinicians to either receive the stigma intervention training or the attention control training. And then immediately after the training, they complete a survey, and then there's another follow-up survey 3 months later. In each of the surveys, the clinicians rate their stigma towards patients with opioid use disorder. They also rate their intentions to get waivered and their intentions to prescribe buprenorphine. And then we're monitoring their CDS use for the 6 months. So in our interventions, both of them are delivered via MyLearning, which is an online learning platform available to clinicians at health partners. And in both trainings, there is evidence-based education about opioid use disorder and medications for opioid use disorder. And they guide the clinician through 4 different scenarios that patients may be eligible for the CDS tool. However, in the stigma intervention only, they will see patients telling their stories. And these are actors who are playing out real-life patient stories, but the identifying information has been changed to protect their privacy. So I thought the best way to share with you about our project is to give you a little snippet of one of our patients.
Help me understand a bit better if you can tell me your story.
After graduating high school in 1975, a friend and I took a road trip to Northern California on a lark, and I stayed for 20 years. I met my husband out there. We had 2 children. We divorced when the girls were little, and the next man that I fell in love with was an IV drug user and a dealer, heroin mostly. He encouraged me to try it a few times, and then I couldn't stop. He always had it. My life fell apart. I went from rehab to rehab. I did a little time in jail. I nearly died a few times from an overdose. But the last time I used was 1995, and I never looked back.
Our results are expected in late 2021, and here is my contact information. I'd be happy to talk with any of you about our trial. Thank you.
The goal of this project is to use a modified experience-based co-design model to improve care and management of patients with a substance use disorder on inpatient rural acute care hospital units. When we think of process improvement, we often look to professionals to identify and fix the problems. Sometimes patients are included in the form of an advisory council or given surveys. Historically, vulnerable populations or frontline staff are not included in identifying problems or designing solutions that impact care. None of us can do this alone. We must include everyone's lived experience. We used EBCD, which consists of a series of facilitated steps where patients, clinicians, and staff first identify the problems, generate solutions, and work together on implementation and evaluation. What makes EBCD an innovative solution is that it is an efficient way to include everyone's lived experience to improve care. In this project, we also used peer champions, individuals with a history of drug use working with us to bring lived experience to all levels of the project. Their expertise is not only invaluable to this project, but it has also been meaningful to them.
I feel blessed to be involved in this work. I want things to be better. It gives purpose to my suffering and addiction, thinking that I'm helping others.
The inclusive nature of EBCD makes success a higher probability and can highlight issues like stigma that may not otherwise come to light. In each of the hospital focus groups, the recurring themes included a lack of community resources, medical management, and patient behaviors. The frustration and need for education were mentioned both directly and by the type of comments that were shared, including:
patients do not want help. They do not want to stop. They do not want to help themselves.
Though comments such as these may seem on the surface to be judgmental and are for sure stigmatizing, they also speak to a need for better understanding of the disease of addiction. We held focus groups with individuals at all stages of recovery, including those who were currently using. From the beginning, individuals voiced their frustration over the misunderstanding most people have of substance use.
Using drugs is fun for the first month. Then it isn't fun, not fun at all. I don't know anyone who lives under a bridge, panhandles in the rain, who shoplifts and risks being incarcerated, who is doing it for fun.
Comments like these are in stark contrast to the clinician and staff comments about patients with a substance use disorder not wanting help. We also heard many stories of stigma and judgment and the impact it has on accessing and receiving care.
It is hard to reach out for help when it's met with a lack of kindness. It deters you.
Stories about being and feeling shamed were very common, like what was said to an individual needing to have a blood draw.
If you would just stop sticking needles in your arm, then maybe we wouldn't be having this trouble finding a vein.
When the patient offered to help by indicating which veins would work, she was ignored. We also heard stories of hope and recovery when someone with lived experience or an understanding of addiction came to the bedside to offer support and help to navigate their care.
She spent a lot of time with me, sat with me for what seemed like hours. It was the first time I had felt love in a long time. If it wasn't for her, I would have left and gotten high.
The patients focused on how they are being treated around their drug use and how that leads to hesitancy to disclose accurate and substance use or history of substance use. This is a symptom of the lack of partnership and trust that they are feeling. Our hope rests on the generated solutions of this project moving forward and showing success. EBCD is an efficient and effective way to include all staff, clinician, patients, and families in healthcare design and improvement. No matter what the project or objective, we can only make real change when we partner with those we serve and start measuring success by how often we connect and listen. Otherwise,
healthcare is taking the control out of doctors' hands and putting it into the dealers' hands.
It is time for a change.
Hello and welcome to our presentation entitled Ending Self-Stigma for Justice-Involved Populations Being Treated with Medications for Opioid Use Disorder. I'm Shannon Gwynn Mitchell, a senior research scientist at Friends Research Institute in Baltimore, Maryland.
And I'm Alicia Luckstead, a research investigator at the University of Maryland School of Medicine. Generally, in trying to reduce the harms caused by the stigmatization of any number of health conditions and other social identities, it's useful to break stigma down into several facets. In this case, societal stigmatization refers to the broad messages, disrespect, and discrimination that is unfortunately commonly aimed at certain subgroups by society. And in this intervention that we're developing, we're going to specifically address the anticipated stigma, which is the anticipation of societal stigma, and the internalized stigma, which is people taking in the societal messages that has really corrosive effects on their well-being, their motivations, and their self-concept.
One of the most overtly stigmatized groups in US society are people involved in the justice system who face discrimination in everything from employment and housing to the attainment of student loans. While it's estimated that approximately half or more of the people involved in the justice system are experiencing substance use disorders, there are few interventions directly targeting this group. Substance use disorder is a chronic health illness, but is not treated the same way that as other chronic health issues, with people with substance use disorder often being blamed for having the illness itself. One of the most effective treatments for opioid use disorder are medications such as methadone, buprenorphine, and naltrexone. Unfortunately, even the use of these medications is often stigmatized, and people who take them are being treated and labeled as unclean as if they're not in recovery.
Because there are not tested interventions that address the stigmatization of this population, in our work, we're starting with Ending Self-Stigma, a program that my team created to help people with serious mental illnesses navigate the effects that stigmatization can have of that condition. It's particularly focusing on anticipated and internalized stigma. On the left, you see some of the inputs for ending self-stigma: academic research, clinical experience, lived experience, and several conceptual models, which we then consolidate into 7 practical strategies that people can learn in a weekly psychoeducation and skill building class that is both manualized and interactive and personalized.
So the grant proposal that Alicia and I currently have under consideration at NIDA is to modify the Ending Self-Stigma program, specifically tailoring it to justice-involved people with opioid use disorder who are considering treatment or using medications as part of their treatment. The first part of the ESS modification process involves a systematic literature review and some stakeholder and focus groups to refine the ESS intervention to specifically target these the stigma for this population. We'll then conduct 2 iterative rapid pilot tests of this modified ending self-stigma intervention, and further modify each of the ESS MJP sessions based on the flow of the intervention and the feedback we receive from the participants as well as the facilitator. Ultimately, we hope to finalize this refined ESS MJP intervention and the materials to be used for it for a future efficacy trial.
In the end, we anticipate we'll be able to both retain the core principles and lessons of the original ESS, which has made it quite effective, as well as tailor the details of content and delivery to the particular situation and stigma dynamics of this particular population. So we anticipate that we will end up with a intervention that is both practical to deliver and useful for the participants in reducing the harms of internalized and anticipated stigma so as to help them engage with and stay with treatment, as well as enhancing their overall resilience and recovery.
Thank you so much for your time. Please contact us directly if you have questions or recommendations.
Thanks.
Launched in 2019, Together in Recovery is designed to foster an accessible, integrated treatment and recovery network in Massachusetts that champions evidence-based approaches, supports multiple pathways to recovery, and puts people in charge of their treatment choices. After conducting convenings all across the state, it was very clear that finding accessible, accurate information about treatment and recovery supports was a challenge. And an even bigger challenge was finding information about the rights and protections for people with opioid use disorder. And that's why we decided to produce the Know Your Rights Toolkit. Together in Recovery is led by an advisory committee of diverse influencers, and they helped us design the toolkit and provided subject matter expertise on the content.
So when we click here and we go into the toolkit, you'll see the landing page. So this landing page right here really just provides that grounding that I just provided for you. But one thing I really do want to elevate here is this equity statement that RISE really recognizes the trauma, inequities, and violence that structural racism has caused for BIPOC communities and people in long-term recovery or any type of recovery. There are lots of barriers that exist to getting the help that folks want, and this toolkit recognizes those, tries to highlight that, and also work to create the foundation so that folks are able to get that treatment without those barriers and create that world where discrimination associated with drug use is over. So to go through each of the sections broadly, there's this navigation bar on the left-hand side, and these are all the sections that you can find more information on, rights and advocacy, and resources. So for example, if I go to treatment and recovery pathways, you'll see here that broad statement that there's no right way to recover. Again, your recovery is your choice and you are the driver in that journey. And this toolkit really does aim to help build that and empower folks to choose what works for them by not only giving them the knowledge, but also the rights that they hold so they can actively exercise their rights in all areas. So here under clinical pathways, for example, what I can do, I can open this and it takes me to all different types of services for clinical pathways for opioid use disorder.
This is a big deal. This is huge for families and impacting people. I don't know about you guys, but I wish there was a toolbox when I was going through my process, because I know my parents and my mom couldn't figure it out. And I wanted to know, everybody wanted to know why, how can we help? How can we be involved? So I'm super excited about this toolbox.
The Know Your Rights in Recovery Toolkit is going to help build a foundation that we need as we go forward. It's going to help people seeking services and seeking support networks. It's also going to be a resource to educate, those who may be on the front lines providing some of those services. And so, we want to celebrate this important, concrete step forward in promoting health equity for all, especially for this vulnerable population. And I really appreciate it because it is putting the person who is struggling with addiction back at the center of the conversation about their care.
I'm author and journalist Maya Solovitz, and I co-founded Changing the Narrative because I got tired of the media being a conduit for misinformation. Most people get their information about addiction from the media, but many journalists don't know about the racist history of our drug laws or their unscientific nature. They think that the overdose crisis was driven by pain patients getting addicted, when in fact, most people who became addicted got their drugs from friends or family members. They think that exposure alone causes addiction and that it can happen in an instant. They think that addiction can turn ordinary folks into criminal zombies. If we actually want to destigmatize addiction, the public needs to know what it really is and how it happens. And in order to teach the public, we've got to first educate journalists to do better. And that's what we hope to do with Changing the Narrative. Thank you.
I got involved with Changing the Narrative because I'm a Black woman in recovery from substance use disorder. And I know all too well that stigma is a form of oppression. So language can either perpetuate it or it can educate to eliminate that kind of oppression.
I got involved with Changing the Narrative because as a writer and journalist, I believe in the power of language to shape our world. For decades, the media has labeled people who use drugs as addicts and drug abusers, but research shows that this language elicits negative attitudes, harsh judgments, and it even impacts people's health care. Humanizing people who have long been dehumanized is one of the founding principles of Changing the Narrative. In practice, this is actually quite simple, and everyone should be doing it. Instead of relying on outdated, stigmatizing language, we simply refer to people as people first. No one should be defined by their behaviors that stem from a mental illness. In working together, we've been able to tell more empathetic stories that truly change the way people think.
I'm here to talk about why we need to change the narrative when it comes to talking about drug use and addiction. We are in the midst of a massive public health crisis, the drug overdose crisis, which is predicted to have claimed more than 90,000 lives in the past 12 months. This has been driven by failed policy and inadequate access to effective treatment and effective care, largely driven by stigma and misunderstanding about drug use and addiction. During the time of COVID, we've seen overdose death rates surge. We've seen worsening racial disparities with rising rates of overdose deaths amongst Black and Latinx Americans. And we've been reminded of the health harms of living in a racist society. When it comes to drug policy and addiction treatment, policies in our country related to drug use have always been fueled by discrimination and by racism. It's time to change that narrative and to educate people about what works and what's effective. As evidence of how the narrative has malformed access to effective care, we've long known that medications like methadone and buprenorphine for opioid use disorder reduce the risk of death by more than 50%, and yet our policies limit access to care, and nearly 50% of U.S. counties don't have a single provider who can offer these medications. We continue to let myth and misunderstanding about drug use and addiction fuel our clinical care and the way we approach people who use drugs. Common myths and misunderstandings include the notion that all people who use certain types of drugs will develop addiction. For example, people who use opioids or cocaine as opposed to more socially sanctioned drugs like alcohol, or that tough love, treating people poorly, being hard on them, will actually help people get better, or that being kind or compassionate to a loved one or someone with addiction or a substance use disorder is actually enabling them or causing harm. We need to undo these harmful myths and let science and compassion guide our approaches. Through changing the narrative, we hope to challenge some of the most common myths and tropes about drug use and addiction to better inform the public, policymakers, clinicians, people working in the healthcare space, people working in law, policy, public health, and to generally change the way we think about and care for people who use drugs.
Just about everyone agrees that stigma is one of the biggest causes of continued growth in overdose rates and rates of addiction in America. But one of the blind spots is that the very point of criminal law is to stigmatize. So the continued criminalization of people who use drugs is a huge barrier to better policies and programming to prevent overdoses and improve treatment. That's why we fight to decriminalize drugs and decriminalize people who use drugs.
We are excited to share that we have created a virtual simulation focused on stigma awareness and opioid use disorder. It's a computer simulation that participants interact with on an individual basis. Then a group of participants come together in a robust online debriefing. This immersive virtual simulation about opioid use disorder was designed to provide participants with the opportunity to experience challenges associated with navigating life as a pregnant mother in active addiction and to feel the impact of stigma associated with opioid use disorder. Opioid use disorder is a treatable medical condition with appropriate access to care. Despite advancements in treatment and the availability of life-saving medications, provider stigma remains a barrier to reducing opioid use disorder and decreasing the number of opioid-related deaths. Creating OUD competent and sensitive healthcare providers will require incorporating OUD education and stigma training into program curricula and continuing education. Simulation provides an opportunity for participants to experience challenges presented in the virtual realm and promotes introspection in response to those personalized experiences. The opioid simulation is an experiential learning opportunity to help participants view OUD as a chronic, relapsing disease for which there is treatment and recovery, experience the role of resilience in opioid use disorder, and feel the stigma associated with OUD. During this simulation, participants play the role of a pregnant mother with an opioid use disorder, navigating the challenges of everyday life, such as obtaining health care, childcare, and finding a job. Participants are presented with opportunities to make decisions based on their previous experiences, current resilience, and pain levels. Though there are many decisions and storylines, all participants progress through active addiction and treatment. After completing the simulation, there is a structured debriefing. First, we work through reactions so we can gauge the emotions of participants. We want the participants to process the emotions before we progress to uncovering frames and why participants made their particular decisions, working through emotion before cognition. Then we ask the participants to reflect upon their experiences through guided reflective discussion, grounded in the objectives of the simulation. Although results are not yet available, we hope to demonstrate that participation in this virtual simulation reduces provider stigma towards pregnant women with opioid use disorder. We also hope to expand the simulation to provide more education on treatment options for women with opioid use disorder and to develop more storylines for the virtual simulation, allowing participants to play additional roles.
Hello, I'm Kelly Thompson, a policy analyst with Public Health Management Corporation and co-director of the Philadelphia Coalition on Children and Opioids. The Philadelphia Coalition on Children and Opioids is a stakeholder group of organizations at the intersection of child welfare and substance use treatment in Philadelphia. Our work focuses on developing and implementing recommendations to reduce the impact of the opioid epidemic on children and families in Philly. We aim to better support families who are impacted by parental substance use and involved in the child welfare system. Today, we're going to discuss one major initiative of the Coalition. The Coalition has developed and is implementing a series of trainings for child welfare staff, including case managers, supervisors, and investigators, as well as legal professionals, including judges, attorneys, child advocates, and related staff, on how to effectively address and support families affected by parental substance use. The trainings include topics ranging from using non-stigmatizing language, understanding the context in which a parent is using substances, addressing the parent's needs, engaging the parent in treatment and services, and promoting a positive child-parent visitation experience. Crucially, the Coalition has developed these trainings through an intersectional lens. We discuss the intersectionality of racism, child welfare system involvement, and drug policy to further contextualize and destigmatize addiction and substance use disorders among families of color, particularly Black families who are disproportionately involved in the child welfare system and have experienced disproportionate consequences of substance-related policies. This is especially important for our work in Philadelphia, a majority Black city and the poorest big city in the United States.
I'm Leo Thorbeck, a research assistant and part of the Coalition team. The Coalition developed these trainings to confront common misperceptions that child welfare-related and legal professionals may hold about parents who use substances. The Coalition conducted a qualitative study of child welfare case managers in Philadelphia, which revealed that previous trainings available to staff did not equip child welfare workers with the knowledge and skills to work effectively on opioid-involved cases. They also revealed that a case manager's bias towards substance use can hinder effective case management, and that a judge's bias can prevent reunification. In conversations with parents who use or used substances and were previously involved in Philadelphia's child welfare system, parents indicated feeling stigmatized and treated in a punitive approach, especially in court. These experiences can slow or prevent parents' recovery from substance use and reunification with their children. When we designed our trainings, we selected a few particularly harmful misperceptions and worked to counter them by compiling science, evidence, and lived experience. In addressing the first misperceptions about substance use and addiction, we make clear that substance use disorder is a neurological disease, and just like many other diseases, it runs on a spectrum, requires treatment, and relapse is possible. We also provide a scientific explanation of how medication-assisted treatment, or MAT, works. To help counter the common misperception that being on MAT is equivalent to substituting one drug for another, and that medication can result in a high. We also highlight research findings on the successful outcomes of MAT. Finally, we share the personal experiences of mothers in recovery who have experienced the negative effects of stigma and misperceptions about substance use while they were involved in the child welfare system, and how these negative perceptions hindered their recovery and delayed their reunification with their children. Their experiences underscore the power of language used by child welfare staff, judges, attorneys, and others working with families, and the importance of choosing non-stigmatizing language when talking about substance use and treatment. So far, we've offered trainings to city solicitors who represent the Child Welfare Department in court and for court-appointed special advocates who advocate for children in court. Both groups were very receptive to our training and engaged in it. In the training exit survey, all attendees agreed that the training increased their confidence in speaking about and using language related to substance use, and that the information presented will impact how they work with families where substance use is present. When comparing the reported levels of knowledge and confidence of participants, both before and after the training, we see a remarkable increase. Overall, participants went from having little or no knowledge to strong knowledge around substance use, MAT, and families' unique needs. The Coalition is also collaborating with Philadelphia's Department of Human Services to host mandatory live training sessions for child welfare workers, and is building online training modules that will be available to all staff. The Coalition is offering live trainings for legal professionals in partnership with Philadelphia area legal agencies and organizations.
Marhaba, my name is Mona Abdullah-Hjazi and I will be presenting our study, Public Health Stigma Towards Substance Use. If you're wondering what I said in the beginning of the video, it was hello in Arabic, commonly used in Lebanon and surrounding countries. The reason I greeted you in Arabic is because our project is in the Arab American community. Before I describe the project, I will explain that the project is a collaboration between a large multi-service agency in metropolitan Detroit called Access, or the Arab Community Center for Economic and Social Services, and Wayne State University. I am a Community Engagement Manager at Access for a federally funded community coalition promoting prevention on substance use and a PI for this project. The other PI is Dr. Cynthia Arfkin, a professor at Wayne State University who has conducted extensive research on substance use in the Arab American community. We also have team members of Halam Allah and Ahmed Balut who we want to acknowledge. We cannot do this research without everyone on our wonderful team. Substance use is a problem in the Arab American communities, like all communities. The community traces their heritage to countries in the Middle East and North Africa. The countries share Arabic as the language and culture that emphasizes the group as opposed to individual. People from Iran, Afghanistan, and Pakistan are not Arabs as they have different languages and different cultures. Similar to these cultures, substance use and misuse are stigmatized. The use and misuse can bring shame to an Arab American family. The community reinforces shame through public stigma towards those who use and misuse substances. The community is diverse with people migrating at different times and different reasons. Major areas of settlement include Michigan, New York, and California. In Dr. Arfkin's work, she documented the differences in willingness to discuss substance use in the community by people born here compared to immigrants, by gender and by religion. By religion, we mean the two major religions in the Arab world, which is Christianity and Islam. In my prevention work, I have personally seen how people do not want to talk about substance use, or if they do, it is stigmatized those who do so. The stigma is a barrier to our coalition's prevention work. Locally, alcohol and drug overdose deaths are increasing among Arab Americans while declining among whites, emphasizing we need to expand our research. Our substance use advocate Ahmed Balut works with our local police department to provide treatment options to care for individuals who have run-ins with the law. The goal of this program is to provide medical care for individuals with mental health and substance use. Ms. Mallah has an expert in health education who helps with prevention activities in schools. So what is our project? We want to develop a reliable and valid scale measuring public stigma towards substance use in the Arab American community. We then will use this scale to measure stigma, components of it, in the next phase of our project, hopefully measure its reduction from our prevention measures. We have established a diverse and national expert panel of Arab Americans at universities who are knowledgeable about research and substance use. The panel includes women and men, immigrants and U.S. born, and Christians and Muslims. Our local team reviewed the published literature of public stigma and modified its items to use for the Arab American community. We added a few items to reflect religious perspectives that were missing from the literature. An example of modified item is, in my community, most people would be willing to marry someone who has been treated for substance use. We then sent the 50 items to our panel for the review. We asked them if the domains were missing and how useful the items were for the community. The next step, reduced the numbers of items with positive scores to 19. Currently, we are conducting interviews in our community. We want to know if the items were understandable, and if so, their responses. We are using quota sampling to make sure that we have data by gender, religion, and nationality. With these data, we will refine the scale. With the new scale, we will survey the community to obtain internal consistency and independent sample and preliminary data and retest reliability. It was work in progress, and we thank our organizations for allowing us to present what we believe is important work to reduce stigma, promote prevention and outreach, and lower the burden of substance problems in the Arab American community. If you have any questions, please contact me, Mona Hijeze, at mhijeze@accesscommunity.org, or Dr. Cynthia Arfkin at cynthia.arfkin@wayne.edu. Thank you.
My name is Erin Fanny Madden. I'm an assistant professor in the Department of Family Medicine and Public Health Sciences at the Wayne State University School of Medicine. I work with collaborators at Utah State University, including PIs Dr. Sandra Sulzer and Suzanne Prevedel, on a project titled Destigmatizing Harm Reduction and Medication Treatment Interventions, Curricula for Tribal and Non-Tribal Substance Use Treatment Professionals in Rural Utah. I also want to recognize project collaborators from the Ute Tribe of Utah, Cassandra Manning, and from the Utah Harm Reduction Coalition, Mindy Vincent. Our work was funded by the USDA NIFA. So the motivation for this project was concern about stigma towards people who use drugs. There's a lot of attention that's been given to stigma towards substance use in recent years. However, research on effective interventions to address stigma is much more rare. Existing research also largely tries to address stigmatizing attitudes and stigmatizing actions towards people who use drugs without much attention to how stigma can also be directed towards people who use and deliver harm reduction interventions and medications for addiction treatment in particular because of these interventions and modalities that they're engaging with. This type of stigma is called intervention stigma and can affect care for people who use drugs too. So based on the findings of a systematic review of research on stigma towards harm reduction and medication treatment, our team created a set of novel educational curricula for substance use professionals that sought to target intervention stigma in particular. So the curricula integrated evidence-based strategies for reducing stigma towards medications for opioid use disorder and harm reduction interventions such as syringe distribution. We partnered with a rural community advisory board and members of the Ute Tribe of Utah to create culturally centered curricula tailored to tribal and non-tribal substance use treatment professionals in the state of Utah. The training was created in 3 different formats, so face-to-face, synchronous online, and asynchronous online. Each training lasts about 4 hours, and all trainings are co-taught by an academic harm reduction researcher, which is myself, and a community harm reduction practitioner with lived treatment and recovery experience, which was Mindy Vincent of the Utah Harm Reduction Coalition. Face-to-face and synchronous trainings involved a lot of interactive components, including discussion of case studies, small group discussion, and open large group discussion. The asynchronous format delivers the training via video modules, and all formats are assessed using pre- and post-training surveys that ask about dimensions of stigma. The initial analyses of the face-to-face and synchronous training were based on data from 65 participants. While we had more than 110 people participate in these 2 formats, not everyone completed both surveys. The analysis of those 65 surveys showed very promising results. They indicated that stigma did significantly decrease between the pre-training survey and the post-training survey, When looking at a post hoc analysis of the results, we found that particular questions showed significant changes, and those were questions regarding methadone, buprenorphine, naltrexone, syringe distribution, and safe drug consumption sites. All questions regarding those showed a decrease in stigmatizing attitudes and intended actions. Analyses of the asynchronous format have not yet been completed, but we do expect similar results because we've adopted a cohort model for the asynchronous course in which groups of learners take the course all together and then engage in live Q&A sessions with the trainers, so with me and Mindy Vincent, where we discuss the material and the content and answer questions. We also have not yet assessed the outcomes of the curriculum tailored to tribal substance use professionals serving Indigenous patients, but we hope to be able to do so in the future too.
Project Echo is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge.
There has been tremendous effort across the state of Arizona to increase the number of buprenorphine waivered providers. And if this was the goal to simply get providers waivered, these programs would have been deemed quite successful. However, despite these efforts, the reality was that very few, about 3%, were actually integrating MAT into their practices. And in looking at why this was, a self-perceived lack of knowledge and confidence in MAT best practices persisted, coupled with an ongoing stigma around OUD and OUD patients. In response, our team here at Arizona State University gathered an interdisciplinary team of specialists in MAT. These experts represent prescribing physicians, a pharmacist, a policy expert, and a harm reduction specialist. Together, this team built and launched our medication-assisted treatment ECHO.
We've been very pleased with the outcomes of the MAT program so far. We've had robust participation and engagement from the community. Nearly 300 learners have joined since we launched, and an average of just under 50 learners join each session. As you can see from these heat maps, our learners are spread across the state, with some learners joining from out of state. They come from rural and metro areas and practice in opioid treatment programs, office-based opioid treatment programs, hospitals, and tribal clinics. Our audience has been very interdisciplinary, including healthcare providers, behavioral health providers, peer support, administrators, and other professionals. This has made for a really rich discussion of the patient cases. We assess learner outcomes through post-session and biannual surveys. So far, these surveys have indicated high rates of satisfaction with the program. Our average satisfaction rating is 4.6 out of 5, with most participants reporting they're extremely satisfied. Participants have also reported improvements in their knowledge of opioid treatment after participating in ECHO, including general knowledge of the treatment of opioid use disorder, knowledge about medications to treat opioid use disorder, and knowledge about related treatment modalities. Similarly, participants have reported improvements in their confidence across a number of domains, from starting a conversation about opioid use disorder with a patient to assessing for buprenorphine contraindications. This side-by-side graph shows the percentage of learners who reported they were very or extremely comfortable with these domains both before and after ECHO. And as you can see, participants reported improvements in all confidence domains. As a whole, we found high learner satisfaction and improvements in learner knowledge and self-efficacy in providing opioid treatment using this ECHO model.
One of the key elements to expanding access to buprenorphine and methadone is understanding that people who are living with substance use disorder are survivors. All too often they're blamed and treated as criminals. Stigma, as we know, is alive and well, both for the patient and for the provider. So one of the things we really want to do at the ASU MAT ECHO is to give the backstory, right? To understand that folks have survived trauma, that they have high adverse childhood experience scores, and then it took a lot of courage just to even show up to the prescriber or provider's office to seek help. When we're curious about people's stories, and when we understand that substance use disorder is a complex biopsychosocial phenomenon, then we can meet people where they're at. We can walk alongside them and witness as they struggle and try to make positive change in their life, and we can kick up the level a notch.
Echo! Yay, yay, yay. Good job.